So really good group of guys. We've been really excited about
Mhm.
putting this together. What do you think, Johnny? What do you think, Matt?
No, I think this is great because I think there's such a changing paradigm in plastic surgery. We've kind of been early adopters of butt implants, but I think that you're going to see more and more alternatives to butt augmentation now in the weight loss revolution. So many people just losing weight, either they had a BBL and now have no fat, or I've seen people who I saw for a BBL consult 9 months a year ago. Now it's finally surgery time, and they're like, "Hey, I've lost 85 pounds," and you're like, "Okay."
Yeah, right. Everything changed, and you
I
you you're just terrified when those people come back for their prep, and you saw them 3 months ago, and they had all this juicy fat, and you even told them. I tell them before I do body banking, before I do fat grafting, hey, I'm gonna need you to put on 5 or 10 pounds, just so that I know that you're not in starvation mode. I know that
Mhm.
you're in an anabolic mode. That you're gonna have surgical anorexia anyway. So we're gonna want you to be ahead, and we want all those good fat cells to survive. And then they come back, they're 10 pounds down instead of 10 pounds up. All right, it's 8:01. I think it's good to start. I'm going to make the introductions. Really, these guys are the stars of the show. My name is Doug Steinbrech, and I'm with Alpha Aesthetics. I'm also really into men's as well as women. I do plenty of women, but I've chosen to have my focus be about men's plastic surgery. Started with Alpha Aesthetics, which used to be AART. Many of you know them out in Carson City. There's a big snowstorm happening tonight in Carson City at the home base. But you've known this as a great place to go for really good implants. I always love these implants. You can use any implants. There's several other Hansen. There's Implant Tech. There are a lot of other ones. This is not just to plug one implant maker. There are several ones. I just love the ones that we had so much that I got involved with the company. But I want to make this crystal clear that you can use any of the other implant makers. I'm also involved with Allergan, and I'm on the board of the Aesthetic Society. And we wrote a couple textbooks, one with Dr. S and Dr. Walden about women's plastic surgery, but the people got so excited about men's plastic surgery, they asked us to write another textbook. So I wrote another one with Tima after the Elsevier textbook. So those are really my disclosures for the night. But what I'm going to do is I'm going to pass it over to our superstars. You've heard me talk in these webinars before. I wanted some really great thought leaders from across the country. So we have the Dr. Johnny Franco. He's a superstar. He's down in Austin, Texas. I've just watched him over the years with his meteoric rise in with gluteal implantation, particularly, but all of everything else. And he's got a crazy practice now with all the massive weight loss. And then he does a conference, and this is my major plug. When you go to the Aesthetic Society in Vancouver, which you have to go in April, he's going to do, the two of these guys do their practices, are doing two talks together. So, Johnny, can you tell us about that?
Yeah, super exciting because we try and take people through the entire course. So it's a back-to-back courses, one on Brazilian butt lifts, lipo, fat transfer, body contouring, and then the second one is butt implants, and really trying to emerge in that to really like, what do you do when somebody doesn't have enough fat or failed a BBL? And I think sometimes people are kind of afraid or which camp they should put them in. So we thought with the courses stacked together kind of gives people the full spectrum of butt contouring augmentation.
This is a really great conference. Matt and Johnny do an amazing job. And it's like watching the Tonight Show because they have this great banter and they have a lot of fun while they're doing it. They're very animated and they're very practical. It's not, like some soft-spoken, polite thing. They're out there jumping up and down, telling you about
Yeah.
all, all the great stuff that they're doing. So without further ado, I think Johnny's going to start us off and then Matt's going to take over. I'm going to be your color commentator tonight, and we're going to answer questions at the end. Go ahead, Johnny.
Yeah, let's just jump into it so we have some time for some Q&A afterwards. These are my disclosures. Really going to talk about modern butt augmentation, the weight loss revolution. So, for my practice, the interesting part, I've always done a steady kind of state of butt implants and augmentation, but, really has dramatically increased recently with the use of semaglutide, tirzepatide. I think one, if you're not at least part of that conversation, I think you're missing out, as Doug stated earlier. There's going to be a change in the plastic surgery paradigm, and those of you that are giving up your evening to listen to this, I think you're part of it. I think you're being forefront of this because whether you're doing the weight loss medications in your office or not, I think if you're not speaking to those patients, if you're not addressing their specific needs, I think you're going to miss out. I think there's a second cosmetic wave coming. And I think those who really can see the special needs that this group of patients is going to have, which is not small, are going to absolutely thrive and not just survive. I used to think that it was this, same patient that we had from our massive weight loss, from the bariatric surgery. I was so completely wrong. Such a different patient group, because you have young, healthy people who've lost weight, that are now super excited. So it's honestly made surgery super fun for me. Definitely challenging when they came in for a BBL 9 months ago. They finally now are having surgery and they've lost 80 pounds. So we've had to do a few audibles. So hopefully this will help you guys with some of the audibles we've had to make. I think there's a lot of different options, not just butt implant if someone's lost a lot of weight, but in my hands, those are limited. Not a huge fan of fillers and other things for butt augmentation for people that are looking for lasting results. Tends to be maybe not as fruitful, and sometimes have some unhappy patients because they think they're going to get a BBL or butt implant result with those. And I've struggled to do that in my practice. So why does this whole weight loss revolution matter for you? If we're talking about butt implants, Monjero tirzepatide, I think finish the year out should be the #1 most sold drug ever when the numbers come in. At this point, we see almost about 2,000 weight loss patients a month at this point. And if you look at it at bariatric surgeries, right, there was 200,000 bariatric surgeries done in 21. There was already over 2 million just Wegovy prescriptions in 22. And that doesn't include any of the compounds, any of the tirzepatides. So the amount of people walking around with weight loss, they either had a BBL or want a BBL or want butt augmentation and now have lost this weight. I think there's going to be so many opportunities of people looking for solutions. And, why shouldn't you be the one providing them? We're the experts. Butt implants have always been super fascinating, and I feel like plastic surgeons, patients kind of get fascinated with them, but never really either know what to do with them, how to do them, where to learn them. Most of us don't learn it in courses. I actually got my start watching Doug, so thank you to him for letting me be here
Yes.
because I watched him back in the day and give some really good pointers about following the curvature of the buttock and something. So if you haven't watched them, definitely worth it. I was learning a little pearl from listening and talking to him, but I think when you talk about projection, in my hands, there's nothing that gives projection like buttock implants. And so when people really are focused on projection, I think something you really have to at least think about and talk about. I think shape. You've seen these patients that just have these such tight butts, and even if you do some cellulite release and different things, I still think there's a limit to like that expansion. Sure, you might be able to do serial BBLs, but can be very very time consuming, costly, and to some degree, when somebody is super flat, there's just a limit to the projection and shape you're going to be able to get because of the force. And Matt actually has a great video showing why butt implants, are so helpful with that. But I think on the flip side, also why you got to be very mindful about choosing the correct implant. And Matt's going to go into some time for that, so I won't get into it too much. I think just a super option you need to think about during the weight loss revolution. Here's some tidbits. I when I do these, I like to give you something you can actually take home. I have a rule of threes just to make stuff super simple for me. So I'm 3 centimeters above the gluteal fold. I'm 3 centimeters from the midline, and then I double that because my first two rules are threes, so it's a 6 centimeter incision. The implants are a little bit more stiff. You'll see this. If you try to force these implants, you can actually get like a gel fracture from trying to stiff it. I think you can injure the skin. I think you just cause more harm. Matt will show you a video in a little bit. It hides really, really well if you're down in that crease. Giving yourself that running room is going to be super helpful. So we'll take you through that, but something super easy to take home. Rule of threes, easy for me. Here's just I'm just going to take you through a case for what it's worth. This is a patient who I'd seen way before, had lost about 40, 50 pounds. And then now, this is her pictures, and so she wants a super athletic, but she wants a very athletic shape. She wants a lot of projection. You can tell that she's obviously lost some weight. She's in a great shape now, but you can see from the backside, not a lot of fat to lipo from her back. Definitely something you could get from her tummy. You see, even with her butt, she's got a little bit of ptosis. I think there's been a seismic change in terms of trying to just overfill the butt to correct everything. She's definitely got some hip dips, just a little bit of squareness, which is frustrating because, hey, I'm super fit. I lost this weight. Why do I still look square? So, all sorts of different options, and we can talk about this later if Doug or Matt wants to jump in. But for me, this would be unless somebody was looking for just a little bit of targeted fat transfer, maybe just hip dips, this would be challenging to just do a BBL or fat transfer
Right.
in my hands to really give them any significant projection or shape to the butt. Matt, thoughts if this person came into your office?
I agree with you. I think if the person said, absolutely not, I'm not interested in implants, I think you'd have to have a very serious conversation with them about the limited change that you'd be able to make towards the bottom half of that butt. I think you could still make a nice change to the waist even, and probably to the tummy. But you're right, anything to the bottom half of that butt, I think without bringing some other volume metric in there, fat's not going to cut it for them.
My favorite is when I ask them what bothers you the most? What part do you want me to treat? The hip dips, some projections, some central buttock, and they look at me and they go, yes.
Yeah.
And you're like,
But it's always the bottom. It's always the excess skin on the bottom that they're not going to fill up unless they have an implant.
That's right.
100%. So this is what we did for her because these combination treatments. I think combination treatments are going to become more and more common. We did some HD lipo. We did some rib repositioning that maybe we can talk about another night, which I think is been absolutely fascinating. We talked a little bit about it last year, but it's made such a difference for our skinny patients. Doug, is that something you're doing? Because I know you do a lot of body contouring in terms of
Yeah, absolutely. Not as much for the men, but yeah, absolutely.
It's been super cool in terms of the change you can make for these skinny patients. We ended up doing an intramuscular buttock placement, and then actually did some fat transfer because I think fat really makes a nice difference for the hips and then softens this. So I'll show you how I kind of combined all of this. Here's her lipo stuff, discussion for another day, but I think you can make. Honestly, these patients who've lost weight are so much fun because you can do so much shaping, so many things. Cute myself for the next slide here. Whether you're using butt implants, fat transfer, I think creating the shape and I really, really come down when I do put people on all four sides. It does take me longer, but I have a hard time from two positions of getting that kind of apex of the flanks down. And I think if you can get their waist down, you solve so many problems. You decrease the amount of fat that you need for the BBL. I think you decrease the size of the buttock implant they need. I think you get the overall shape better. So, the more you can do in terms of shaping, the better and happier they're going to be long term in terms of this, because now you've reset their proportions, which I think is absolutely key.
I can do just sculpt.
You don't have to watch me lipo all. You guys lipo all day long. Probably have nightmares from lipoing.
I do.
You have little butt implant action, and so part of the athletic butt. She's super thin, super fit, just trying to get a little projection. We use the fat to soften it, also fill her hip dips. And what's cool is I draw a line right where the butt kind of comes together like that. So this will be hitting well into the butt area here, and we give some projection, and then we'll come do the rest of the things. You're welcome, Bim.
So this is cool because you can see I just follow those same rules of threes. I do have them stand up. I draw where the top of that butt is so my incision doesn't come up. So even in a thong, panty, things like that, it's going to hide very, very well. I think sometimes where people are so afraid that you're going to be able to see those incisions, much like an infrared fold breast augmentation. Sure, if somebody's bent over lifting their breast, yeah, you're going to see it. But same thing with the butt from a standing position, even in a Miami tiny bikini, they're going to hide really, really well. I do love to put a betadine lap towel, IO band over the top. It just keeps you from dragging sutures over the butt crack, doing anything like that. I think, you always worry about where your assistants put stuff. I'm a huge fan of, I don't let them ever put instruments on the patient. I don't let them ever rest anything on the patient because you just never know what tip is going to touch what. The more you can keep things off, I think it's inadvertent stuff is what causes problems, not the actual surgery of us ourselves. So my 2 cents for what it's worth in terms of that. Matt has a better picture of this later going on, so I won't do too much, but
Hit our incision there.
just finding that little spot there where you go down, you can actually see the muscle. You can see there's actually a little bit of fat. I do a running, some running room, and Matt will show you this because we both do the same because you want some room to go. If you're going to have some wound closure issues right on the skin, you want to know that you got a couple centimeters. That's where my rule of three comes. I want that space between the incision, the fat to close. We'll close the muscle over the top to make sure we're in a great spot. So when the implant goes in, you have a lot of layers and a lot of room to close that. So I think that's super, super important in terms of.
Here we got our sizes. We're gonna slide this in. Next to with the breast hog, just want to make sure the pocket is just perfect. Don't want it too big, don't want it too small. Want to sit just right. Now's the chance to get it perfect, perky peach. 1,
So I use a saline sizer, super easy, just from your breast implant. So I put a sizer in, make sure the pocket's just perfect, just like your breast implants. I didn't want to take it in and out. Once I put it in, I want to be done. I want to be set. I do use the Keller funnel. This gives me a chance to open it up. I do believe in the glove and fit stuff because you don't want to make the pocket too big because I feel like it moves around. But if the pocket's not big enough that you can get a tension-free closure, I think you're setting yourself up for problems. I think both Matt and I overfill the sizer just at least a little bit. I think he does a lot of it, but just with the goal of making sure that closure is tension free. Pearls on that. I know you talk about it too, Matt.
I agree with you. I think put the last thing you want to do is put that butt implant in and find out that you do that not have enough room and that implant is sitting on your incision closure, and or you can't close the muscle over it because it's sitting too much. 'Cause trying to get that butt implant back out, I think, is just not easy, and then you just start getting frustrated, and then the pocket's not right. So I think taking that extra 5-10 minutes, putting that sizer in, saves you so much on the back end, both in a result and also being able to sleep at night during that early post-op period.
I think one of the most common errors of rookies doing this is they're a little bit tentative. They don't want to open up that lateral
Mhm.
pocket. They're thinking sciatic nerve. They don't really know the anatomy. They're always worried about that. They're very tentative, or they don't want to. They also like Johnny was saying before. You have to follow the curvature. The globe is round, and you have to follow the curvature. So you have to keep on diving down. But inadequate lateral dissection will never do you well because what you will do will have too much pressure sitting right against the incision and you'll be too scared and you're not going to want to cut your implant and you can't get that implant back. So you're going to close it under too much tension. And then that's a setup for dehiscence.
Yep.
So get a nice lateral dissection.
100%. If you're worried about it, you think it's too tight, it's too tight. Think it's just going to be fine. It won't be. That's probably the by far the biggest. And Matt will talk a little bit about implant selection. I think having a good selection of the pocket. I mean, even if you have to put the sizer in twice, I mean, it's going to save you so much time going in and out. And then I do think you set yourself up for infections and other problems when you're taking that implant in and out because you'll see they're stiff. They're a little bit harder, so they don't just pop in and out just like a breast implant.
Breast implant.
Not that you love doing that either.
Here we got our sizers. We're gonna slide this.
This is just what I'm talking about because once you get your implant in, the closure, and you'll see both of us bring it up over and over, is key. Those edges and muscle should come over it so easy, and I think that's been one of the biggest changes for me. Going to intramuscular, you can actually close that muscle over the top. You got that fascia and muscle that you can take really nice bites and close. So you can close the muscle fascia, you can close the superficial fascia, the dermis stuff. So you got multiple layers here. Let's see if you can see it to really, you see how that implant, and the implant almost, when you get the pocket just right, will almost sit down. It sits down right where it's supposed to. And if it doesn't sit down right where it's supposed to, now you got that edge pushing. Every time they turn to a side, they're pushing against that edge. So you really want it to sit right where it needs to be, or you're going to be set up for problems. You'll be back, and then now you're trying to revise that, and that's a struggle bus.
I think that's a good feedback for you too, as you do this, right? As you sort of like, what can I take home? What can I learn from it? If you're finding after you do your intramuscular dissection and you put that implant in and you don't notice that sort of that implant goes in and sits down, then you're not really in that true intramuscular plane. You're a little bit more superficial, which we've all started as we try to get it. But that's that feedback that you're looking for, Johnny, is that you're absolutely right. It goes in, then it kind of goes whoop, and it sits down. And that's when you hit that right depth.
You also may find that you're going through the muscle, it looks really great, but suddenly in the middle of the muscle, you start to see yellow. You've gone through the muscle out laterally, again, because you're underestimating the amount of contour that you need to go down, and you're actually poking through the fascia and you're fat. Now you have a dual plane, which you don't want to do that for an intramuscular implant.
And you know what's interesting, and I don't know how you guys feel about it. I feel like if you actually get deep enough into that plane, you can actually find a really cool plane where you can almost kind of push through and just slowly, lightly disset. I've never been a fan of just huge blunt dissection because I do think I don't want this to be, dry, just like my breast implants. I want it bone dry. I want to be super precise where I'm doing this, but there's actually a plane when you get deep enough that kind of separates really nicely as you kind of go along. I know Matt does his a little different to kind of artificially dry that up, but something to look for. I want to show you this, and not that this is about fat transfer, but pretty cool with the ultrasound to be able to see the implant. I know some people are worried about doing fat transfer with an implant because it gets in the pocket, but honestly, super easy to see the difference. And I'll show you a quick
All right,
little
give me-
video
cool.
here.
So right there, you can actually see the implant all the way down at the bottom. So you can see there's the implant. Then you can see some of the muscle right above it. And then you can see there's the fatty tissue right there. And so pretty cool. And then we'll bring our cannula into view in just a second. And then you can see our cannula right there. You know, so it's above the muscle and that nice spot. And then that's pretty cool because you can see all the things. You can see the cannula, you can see the muscle, and then now you'll see the fat coming in. And so that's above the muscle, but still filling all that nice fatty tissue. Pushing the muscle down. Boom, you're welcome.
And I think this is so cool because sometimes people get worried about doing fat transfer with an implant because I'm going to get it in the pocket. But if you actually got some thickness to the muscle, one, you've already separated that pocket. You can see it's nice and tight. You can check the implant. You can actually see the fat still really, really well. The implant doesn't make any difference from that. But pretty cool how easily you can see your planes and just kind of do some fine things with the ultrasound. You can even evaluate your buttock implants if you needed to, and so forth like that. So still have all the options on the table. Just because you do a butt implant doesn't mean you can't do some targeted fat transfer or other things. But now what little fat you have, you can really do just a little artistic work, which I think all three of us love doing in terms of this.
All right, Tim,
Can I just pop in with fat grafting?
Sure.
I use fat grafting or body banking. I use fat grafting probably 90% of my glue dogs, just because I can use a smaller implant, keep the complication rate down, and use their own fat for a little bit on top to get extra projection. However, it's always in a different pocket. It's with different incisions, and it never mixes with the pocket. It's always a different route because there are different. I always say that the body is not just a single storied house. It's an apartment building that is 3 stories high. And I'm always going in a different exit, a different entrance for my fat grafting, and I'm going in a different plane that it's impossible for that to bleed back and get into the pocket. So as long as you keep it separate, 2 separate planes, then you're fine to do fat grafting.
I
Doug,
couldn't agree more. I love that. The more you can do fat, the more you can decrease the size, and then I do the same. I go through a different incision because I think putting fat in the butt pocket is a setup for all sorts of problems.
Absolutely.
I love it for the size, just to help soften up to minimize the chance of show, especially on thin people. Doug, if you're starting out at butt implants, would you, where in this sort of pathway of doing these, do you think you feel comfortable doing the fat transfer with the butt implant? I don't think I would recommend that to the novice or the person starting off. I think that's probably a little bit too much, at least in my hands. It probably wasn't, till I don't know, 10, 20 butt implants, I probably started to feel comfortable enough to start adding fat with it.
Well, for me, I've always been really comfortable doing the fat grafting and keeping it in separate spaces. And I always have 3 pointers for rookies. Number 1, never make any, whether it's a chin implant or a calf implant, never make that put all the pressure on the only procedure you're doing. I always mix it with something else. You're doing something else and you're like, hey, while we're doing your breast, or not breast, but while you're doing a lot of liposuction, do you want to slide in a gluteal implant or a calf implant? Don't make it your only thing because all the pressure goes on that. And if you're just starting out, that's a problem. Number 2, don't swing for the fence. Don't make it the largest, and don't promise the largest implant you've ever put on your very first try. You're going to have breakdown because you're not going to do adequate lateral dissection. There's going to be too much pressure on the pocket. You're inexperienced. You don't know exactly how to do the closure. You're going to put not enough tension or too much tension on it, on the closure, and it's going to open up. So don't make it the biggest implant. And so what I've always done is I start with the BBL, and for my very first implant, I encourage people to make sure it's a clean pocket, but to use the smallest little, like almost something you'd see in a McDonald's breakfast sandwich. Just a tiny little biscuit. You're going to get in. You're going to do the rest with the grafting. They're going to get the result they have. But because you're going through all the steps, you're going through everything, but because you're not using a huge implant on your very first one, then you can do it. And I argue to my people, as you get better, you can move to larger implant as long as you keep the fat in a different area, you can go down on the fat that you're going in, and progressively you'll get to full implant on a very slender person and no fat grafting. So that's what I think is a good way to do it. But to Matt's point, you have to make sure that you're comfortable on keeping it in different planes. You can never, you're fooling yourself. And I did it. I was on a panel and somebody was doing a body lift and they were injecting right in through the incision to do the fat grafting. Everybody knows if you don't go through through a different incision, if you're going right through your body lift incision, all that fat's going to bleed back into your incision, and you're going to have a circumferential dehiscence because of a bunch of fat that's in there that has no blood supply. So you have to keep them separate. All right, guys, keep going.
Yeah, and the other point is, I think people are surprised because they want to equate this to a breast implant, that if you do a 200 or a small butt implant, they're not going to see any difference. But I just don't think that's true. I think people see
Right.
more of a difference with the implant, even the smaller sizes, because typically it's a small person you're putting this in to begin with. But the stiffer implant makes a bigger difference. So don't underestimate the power of the butt implant for sure, because you're going to see more than you think. But here's just
Our team, this is good. So,
the result
you know,
stuff here.
That's a great, sweetheart. So we filled out some of his lower hip tips, put a little buffer in over that implant, you know, a lot of projection.
And then I glue mine, but so here's just some result stuff. So you can see a little HD again. If somebody's trying to look super athletic, as thin as she is, you know, to get a butt that looks like that with just fat transfer would have been impossible. You know, just not enough fat. I think it's all about the shaping, getting the sweetheart, getting everything coming down, everything coming together. So, you know, I think this worked out really well from her, from a transition of getting the hips down, filling the butt, you know, making the waist and everything look super nice. So, you know, change the shape of her tattoos a little bit, but you can see how it actually kind of lifted the butt and where the
Yeah.
tattoo fit in terms of shape and some of that. So I'm gonna turn it over to Matt. We have some other diagrams we can show this, but I think Matt has some great introp videos, and we can circle back to this if you guys have questions at the end.
Just to
Wonderful.
move in really quickly, though, all the diagrams you're going to see here are from the textbook, from the male plastic surgery textbook. So you don't have to take any notes. And in fact, we have bullet points, bullet steps at the end of the chapter for buttock augmentation, where it has step by step every single bullet point that you need to do. So it's all in the textbook, so you don't have to take notes.
Wonderful. You guys
And
can
honestly,
see-
if it's money well invested, like I said, and I don't receive any royalty stuff things. I mean, I learned from Doug. I actually watched the book. I looked at these. I review these pictures, because it's one thing to do one, go back and then relook at the anatomy. Because like Doug said, you sometimes get a little nervous about where you are, even if you got a picture, and going back again. That's what makes it easier and easier every time.
Absolutely right. It's a good. I have no financial interest in the book either, but it's a really good book. I recommend it to everybody. It is good. All right, I've got about what 10-15 minutes or so. So
Yep.
I really wanted to sort of talk to you guys about why I started using the butt implants more, and the things that I really learned, or the things that I found difficult, that I thought really helped. And I encourage, obviously, Doug and Johnny to jump in and talk to us about it. So Southern California, I have 2 offices. I'm a paid speaker for Vaser and Renuvion. All right, so why did we stop the butt implants? Because they were around. And I really think we stopped the butt implants for 2 reasons. Number one, I think the population started gaining weight, and we started injecting fat into people's muscles. So we were able to get actual muscle volume growth with fat. And then I really think this video helped to put a lid in butt implants for a long time, which is an over dissected pocket that someone can then flip, and it's a subfascial placement. And I think when you see that, you say, I don't want to do that. So why are butt implants coming back? Well, we stopped doing intramuscular fat injection. And once we stopped doing intramuscular fat injection, that has really limited us on the ability of how much we can volumize and grow and shape that buttocks. I think the other thing that's really changed, which Johnny hit up on, is we're actually seeing a net decrease in weight in the population with the advent of the GLP-1s, the semaglutides, the tirzepatides. And I think those 2 combinations actually are really going to be pushing butt implant augmentation significantly as we continue this. So how can we help to integrate you in this practice? So I watched Doug's videos, I read his book, and then you kind of teach yourself a little bit too as you kind of go over it. And I want to sort of share the things that I learned that I felt really helped me. And like anything, the first thing is patient selection. So let's talk about a good patient selection. You want someone that overall has some shape to them, or at least has a good buttocks that aesthetically at least looks okay, and that their main goal is they want to add volume. Volume is the key. Will you get a little bit of shape from a butt implant? It's round, so you get a little bit of roundness, but very, very little. Mainly what you're getting is volume and projection growth. And I think Johnny hit on that earlier. I want to show you that. So this is really a 200cc butt implant that we did. There was the before, and here's the after. It's a round implant, and you can see as we sort of spin to the side, we do get a little bit of round shape. We get some nice volume. There's the incision, hides nicely in a thong. And you can see, yes, we did round out a little bit. Overall, we got nice volume change, and this is really in a 200cc implant. It doesn't need to be a giant implant. We'll get into reasons why. And the main reason why is it's not a breast implant. So when we select an implant size for a patient, this is something that took me years to kind of learn, is how to measure it out. Well, you want to take the widest portion of the butt. So in this person, we would measure that out 17 centimeters. And then we subtract 2 centimeters. And we subtract 2 centimeters because we're actually going to make that paragluteal incision that I outlined in the red there 1 centimeter over, and I subtract another centimeter just for the soft tissue. And that allows me to pretty confidently say, yes, I know when I put that butt implant in, I've got enough room to make that pocket and make sure that that implant is not going to sit against my incision. And I want you to, this is actually in real time. So this is actually how we do it. I measure out here, and then I'm going to subtract 2 centimeters off that. So here that's about 17 centimeters, and then we're going to subtract it down. We got 15 centimeters. And that's how we do it. Really easy, just like that in real time. Now let's look at this. I have a 650cc breast implant on the right side, and I have a 460cc.
You guys are multitasking. Jump in and pay attention to this, because I think this is phenomenal.
Thank you, thank you. So look at this. Look at this difference. 460 on the left, 650 on the right. And when I put pressure on it, watch how this 650 breast implant actually squishes down lower than this butt implant. And the key takeaway here is that you cannot treat this butt implant like a breast implant. You cannot try to squeeze this butt implant in, because it will not squeeze. If it's against the incision, if there's too much tension, it will not conform to that. It will actually break the incision down. So we have to choose the right implant based on that diameter, size, and that volume.
Matt, just a key point. I mean, don't you think as patients sometimes come in and be like, oh, I have 500cc breast implant, so I need a 500cc or a 600cc butt implant, and they're not apples to apples.
Yeah, no, you're absolutely right. So I like to show them that this video too. That's actually one of the reasons why I made that video. And usually my discussion with patients are, I try to keep it simple. So I usually say, hey, a butt implant's going to behave almost double as a breast implant. So if I put in a 300cc butt implant, I want you to think of that giving you the same push as a 600cc breast implant. And then I show them that video. And I think that that's relatively accurate. I describe that as the push effect of that butt implant because it's firmer. How about you?
I've never put a rule of thumb like that, but I love that. I mean, I definitely think that you don't need as much butt implant as you do breast, because in their mind, they think that makes them proportionate, but really it can be overdone and then detract from the other.
Absolutely. I totally agree.
Other thing, and I learned this actually from Johnny, and he showed this as part of his rule of threes. So I measured 3 centimeters from the bottom of that butt fold. When I started, it was 1 centimeter, and then it was 2 centimeters. And now 3 centimeters is actually a nice happy median, at least in my hands, because you are going to get some downward descent of that butt implant. The muscle helps hold it up, but you've got to account for that. And that's actually been one of the things I've done that it has nicely changed.
To that point, it's okay when your implants come out for the first post-op visit or the second, if they're overcorrected, if they're a little bit high, that's okay, because they will drop a little bit. But if you weaken out, take too much of that muscle below, you're going to lose your pocket.
That's right. That's right. I'm a very visual person. So when I do my markings, my surgical markings, I like to actually just mark out my actual dissection. And this should look more round. As Doug pointed out, it was oval when we were running over the slides. I thought I chose a round shape, but it's oval. And I'll actually mark out that halfway of that 15 centimeters. I'll make that horizontal mark. I'll make that vertical mark. And then I'll just make my little 7.5 centimeters to get to a 15 centimeter base width. It helps me when I'm going along to just make that dissection and know that I'm relatively in the ballpark and that I adjust them with the sizer like Johnny showed. I want to run you next through a couple key points on the surgical dissection. I'm going to go kind of quickly. I know we've got a little limited time. We actually show these videos in full length during our ASAPS conferences, so please come and watch them there. The first thing, I think almost everybody starts subfascial, and you do it because it's easier, because it's an identifiable plane. However, as you see your patients back 6 months, 1 year, 2 years later, you're going to notice that implant sort of falls down, and you start to recognize a subfascial placement with at least the implants we have available in the United States does not cut it, and we need to move to an intramuscular. And as you get more confident in that anatomical dissection of the buttocks, you start to make that intramuscular dissection more. And I hope to kind of give you a couple pearls that I learned that helps to give you more confidence and helps to show you how to do it.
Here's a couple of things.
Johnny's already showed this to you. I can't stress enough. The lap placement on that buttock helps to keep everything clean. And he already went through the reasons why. I do it too. It's really helped out. I'll always mark my incisions prior to placing that betadine lap and the IO-band. So I want to stress that too, because I think when you're starting, sometimes you'll put that IO-band. Johnny's probably chuckling because he's done it himself too. I imagine.
Yeah.
Do your markings before placing the IO-band.
Yes.
Okay. So this is going to be a little counterintuitive. The easiest way to start to do your intramuscular dissection is once you make that incision and you enter and you hit that muscle, sweep off a little bit of that fascia. Identify that muscle. Let yourself go in that subfascial plane, see where that muscle is, give yourself a nice cuff so that you'll be able to see where you need to release the muscle, and you're giving it a little running room to actually sort of fall back and fall into this intramuscular placement. And that's really the key. We're going to look at falling into it. So that's actually me. I'm releasing all that fascia off of that muscle that you can see. And we do it for about 3 centimeters just to help really show it. Once I've done that, this is something that I've added. I inject a little tumescent. Muscles can bleed, so I started doing the tumescent. So I thought, well, this could help with hemostasis. But what I found then was it actually sort of blew up that space of that muscle and actually really helped to identify that intramuscular plane better. Just like with facelifts, when we inject a little bit of tumescent, we can sort of identify that the plane of separating the fat from the SMAS.
Good.
Once I've done that, you can see I can actually lift this muscle up, and I'm just going to tap it with my Bovie. And you're going to watch the muscles just start to fall. And I actually put this because this was a little harder plane for me to find. And you can see I just take the ring forceps, and you see that muscle's just literally just spreading. Once we got into the right spot, we were just tapping it with the Bovie, and then that muscle just falls back and opens up. And that's the beauty of doing this intramuscular dissection. As you're finding it, the plane's actually going to show itself to you. You just need to come down and just tap it with the Bovie. The muscle's going to separate for you.
All right, so I fill up that sizer, which remember is.
And Johnny already talked about this. We use a sizer. I always use a sizer. I overfill my sizer. And Doug hit up on this a little bit. The reason I always overfill the sizer, let's say if I'm putting a 300cc implant in, I'm actually going to fill that sizer up probably about 500, 550. I want to see what the lateral edges of that implant are doing. I want to see if there's any bands that I missed on those lateral edges that I need to release to help to get it both to look, I think, more aesthetically pleasing, but also to ensure I've got enough room in that pocket.
Make sure the sizer you're using is wide enough. You want the base width of the sizer to at least be, equal, if not a little bit greater than your implant. So, because they're not going to be like matched, implant for implant.
Wonderful point. So I'm always using a low profile sizer.
Mhm.
I assume you are too, right? To get that base width.
Mhm.
This is another what seems like a very basic thing, but if you've been there, you've made this mistake. Once you've dissected one pocket, you want to put the implant in. Do not put the implant in. Put a lap in. I use betadine and TXA and move the other side. If you try to dissect the other butt implant pocket over the implant that you placed in on the other side, it's exceedingly difficult and it will make your life miserable. So please don't do that.
I couldn't agree with that more. Completely agree with that more. For a second reason is it just gives you that much more time to check your hemostasis, particularly with the TXA. Make sure you have the blue stripe coming out. And you can do this as a rookie. I swear you can do this. You can go back and push the implant on top of the lap. And if the people don't do a correct lap count, you can leave a lap in. I've never done it, but you have to be very careful. Leave a little bit of blue out and make sure that you get that lap out when you go back to put the implant. It's very easy to do as a rookie.
That's
I
absolutely
think
right.
all three of us agree that, just like you would a breast aug, I mean, meticulous hemostasis, bone dry pocket. I mean, blood in the pocket, I think is a problem. It's a nidus. I think we all treat this very similar to breast augs, where precision pocket, precision hemostasis.
I think that's another good point. Like I talked about when you talk about how the implant drops down. I think another good feedback to you as the surgeon as you're doing this, if you find yourself going through the intramuscular plane and you say to yourself, man, this is bloody, you're not in the right plane. When you get in that intramuscular plane, it is relatively avascular, except for the blood vessels that you see going, and you should not encounter a lot of bleeding. That's the feedback that you're looking for. And I sat where you guys were, and I heard people say that, and I thought, how is that possible when you're dissecting muscle? But you find it. I assume you guys feel the same way.
Absolutely.
Yeah.
Wonderful. All right. Always check, make sure
It's
there's
because you're
zero pressure.
too superficial, like Doug was saying. So you're not actually in the plane. You're too superficial, and you're going up and down through it. So you're basically cutting through that muscle on all sorts, and you're basically hamburgering it. And that's why I think you get so much bleeding and pain and other things.
Yes. Always check that there's no implant, no pressure from that implant. And if there is, just like Doug said, you have to release stuff further laterally. One thing I want to show you, this is the beauty of the intramuscular section. Look at this. I'm going to do a little horizontal or figure 8 in there, just kind of like similar like a tendon repair. And it allows us to totally close this muscle over this implant. And the beauty of this is, that muscle is holding that implant for long term. You also know that in case you get any skin breakdown from patients maybe being non-compliant and sitting, that you've got healthy muscle underneath it. You can just rest assured a lot easier when you do this closure correctly. And just like Johnny was talking about, look, that implant's actually sitting lower than my incision. We did a stair step incision, but that implant is lower. It's down on the ground. That's how you know that we made the right depth.
Also, too, you could see how thick your muscle is. I think people are surprised that that muscle's got a pretty good thickness when you grab it there. I mean, it's not nothing.
Yeah, that's right. Usually, I mean, in my hands, it's usually about half an inch or like a centimeter in thickness, typically. I always close the superficial fascia, like Johnny said. I didn't originally, and sometimes I could get an occasional fluid collection. So just really help to decrease dead space and also limit just tension. Standard closure like we would. I then do deep dermals and then a subcuticular. Again, you want minimal tension on that. This is something that I've added that helps me sleep at night, and I really like it. So I think post-operatively surgery goes great. How do we make sure that when the patient goes to the bathroom, when they're at home, that they keep these areas clean? And I don't like to worry about that. So what I do is I actually do this I dermabond. I wait till the dermabond dries, and then I put a little telfa and a little remaining strip of my Iaband over this area that you can see. And the key is make sure you take that low so that they don't irritate. So whether they have to have a bowel movement or they are just potentially sitting in urine or who knows what, because you can't go home with them, you can rest assured that that area has been sterilely placed with dressing, and I leave that on for a week, and it's made all the difference in the world for me.
That's interesting. That's cool.
Johnny's showed the slide. I agree with it. I'm very strict on this. No sitting on the butt at all for the first 2 weeks. Then we use a butt pillow for another 6 weeks after. It's just made a world of difference for me. At their post-op appointment, actually the first time I take that dressing down, I take a photo of it. I show them their incision, and I give everybody the same speech. And I tell them, hey, this is going to be a little bit blunt, but I just want to be clear with you. Look at this incision, totally healed. We're a week out. And I say, only you can screw this up now. And I mean that, right? By sitting on it, by doing yoga, by going down a water slide. And these are all things that have happened to me. And so I have those discussions with the patients, and that's helped a ton. Is this how I started? And that's how I want to end it. No, of course not. I started subfascial, and then I slowly got my way down. So if I'm in your shoes, I would encourage you, don't start subfascial because you're going to be very unhappy with the way those implants come back in 6 months, 1 year, 2 years out. Go down, do that little sweep of subfascia, get comfortable, identify the muscle, and then start dissecting into that muscle, and you'll find your muscle will be getting thicker over time. You'll find that you'll be going further out over time, and you'll have less of those buttonholes that Doug talks about that we all happen. The other thing is I used to routinely go above 400 cc's with butt implants when I started. That is so rare nowadays. Most of the time, I'm sitting around a 270 to a 350 cc butt implant, and that's made my life so much better, and I can't stress that enough.
Even if I'm gonna go above that, I've made them stage it, and so I've done it. I've made that pocket create, let that pocket get nice and tight, and then move it to a different area in terms of things.
It's great. Can I ask you guys a couple of questions? Number one, I'm gonna talk about some things that I've changed. When I first learned it, I learned it from another great surgeon well, I'm gonna say it was Mendieta, and he was doing them. Then he stopped doing them because everybody went over to fat. But he was doing the duckbill, and he was spreading it and spreading it, and there was so much bleeding. The first one that I did, it looked like there was like a multi-person murder in the OR. There was so much bleeding. And I switched, I got rid of the duckbills. I went intramuscular. I kept it dry all the way through from the incision all the way to the end. And you do encounter some perforators. And if you do that, you have to be ready. So you make sure that you have your Yankauer suction. You make sure that you have long insulated forceps and someone that is ready to bovie. You have to have that ready because when you get one of those, they can bleed. So you want to make sure that you're ready for that. Your staff knows it. You have your headlight on. You can see it clearly. You put your long tipped forceps on it. They buzz you and it's done and you're free. You keep it all clean and you're good. The other thing is when we started, we were doing one incision. We thought two incisions were old fashioned, completely changed the other way. Went from a single incision that had repeated breakdown and repeated dehiscence to going to two incision, which I think hides in the shadow actually better. It was less tension. And God forbid, if you have problems on one implant, it doesn't communicate over to the other implant. So the other things I was going to ask you guys, let's talk a little bit about complications. What do you do? How do you think seromas come up? How do we prevent them post-operatively or intraoperatively? What causes them? And then how do you treat them? And do you guys use drains with your gluteal augmentations from the get-go?
I don't in a primary butt augmentation. The only time I use a drain is if there was a seroma or something that I'm treating. Two, if I'm doing like a site change and maybe a topic we can talk about another day, but if I'm doing a site change and I got that space, I'll do there's actually a couple different things that I do, and so I'll put a drain in for that.
I do not use drains with implants. I just inherently think it's I just don't like the idea of seeding an implant, whether that be early on or whether that be 6 months to 5 years down the line. So I don't like the drains with implants personally.
When I started, I used to use them because that's how I was told or started. And even with the counter incision on it, it's just another scar. And I have a hypothesis, and this is my hypothesis. Number one, patients hate them, particularly for gluteal implants. But I stopped after 1 year. I stopped using all drains and all gluteal implants. They love the fact that you don't have any drains for that. But number two, I think for the glutes and for the pecs, you have to make your lymphatics start working immediately. Because if you hamstring them or if you make it easier for them not to do their jobs, i.e. put in a drain so that they don't have to work, you're going to get some direct atrophy. And then when you pull out your drains 5 days, a week, 2 weeks later, you're going to get a rebound fluid collection. I really honestly believe. So that's why I want to get my lymphatics working from the get-go. Back to you guys, what causes, Johnny, Matt, what causes a fluid collection, a seroma, where one side, 5 weeks, 2 months later, one gluteal implant, one starts swelling up to the double the size? How does that happen?
I think there's two parts to this. One is I think if you're too traumatic at the initial surgery, I think you cause a lot of inflammation. I think you do damage some of the lymphatics. I think you get this rebound, hyperinflammation, and then it takes a long time, and you get a lot of that kind of peripheral flow into it. And so I think that sets you up for a seroma. I think prolonged healing. I think if people are back to exercise too quick, because I think the easing people in, I really coach them like mad about how much I'm bending over, how much I'm doing, because typically at that month area, I think you start to form a nice pocket, and then you get the shear because they decide now they want to go on the treadmill for an hour. And I think you get a shear effect on the inside that leads to a seroma if you get a late one a month. Usually it's been either intercourse is probably the most common culprit for a late seroma for me, or premature exercise.
Yeah, Doug, I've got a theory about early seromas, which is just my
Yeah.
theory, which is I agree with Johnny. I think it's trauma. I think most of the time it's heat. So I think that's usually coming from your bovie. And I kind of think of it like this. I think just like burns, once we hit a 2nd-degree burn, we create a blister fluid collection. And I think a lot of early seromas, whether it be from lipo or from bovie related, I think is a heat trauma, and that's your natural body's response to that trauma, makes fluid. Later seromas, I agree again, actually with Johnny. I think it's typically meaning that something happened, some type of activity, or there may have even been a little bit of bleeding associated with it, and we got more inflammation, more irritation, and the body reacted and created some fluid.
What do you guys put your bovie at, just for the people in the audience? They're gonna ask, is it 55, 45, what, 35?
I do 35, 40.
Yeah,
35,
I
40.
do 45.
Because
Yeah, I
I
think
Blend and spray.
because I think that just doing precision, like you're saying, Doug, I think there's a lot of credence in this in terms of the prospective hemostasis. I know that Bill and other people talk about this for the breast stuff, but
right.
when people let bleed, I think blood is an irritant. I think that causes problems. I think it causes inflammation. I think, in the breast it causes capsular contracture. I do. I think in the butt, it causes the prolonged swelling and the pain. I think once you get a bleeder and you get blood in there, it's harder to see it. I think sometimes people aren't ready, like you're talking about, and now they just turn the bovie on 100 and just start trying to fry everything. And to Matt's point, now you've caused so much thermal energy damage in there, that leads to problems.
We've all been there, and we're talking about the perforators, because if you miss it, the problem is that blood vessel retracts into that muscle, and the muscle naturally just folds over it, and then you just get this spray. So we've all been there. If it's okay, I'd spend just 10 seconds on what I do. I grab my lap. I've got some TXA there. I've got a betadine TXA solution. It gets dipped in there. I kind of just do it like a trauma style. I'll shove it in and make sure I got some pressure. I let it just sit. If I can't find it, I let it just sit for about a minute to 2 minutes, and then I will slowly peel that back, and I'll be pulling on that muscle to unfurl it, to see where it is, and then I zap it with that bovie. That's at least been the most effective way if I get one of those perforators that pulls back in the muscle.
Yeah, and the most important thing is don't freak out.
Yeah.
All of us go intramuscular, right? There's some people, but Doug Sinrest, he's a buddy of mine. He's like 10 blocks down from me. We are really good friends. We're naturally, you would think we have competing practices, but we don't care, because we're just buddies. But he does subfascial. He likes it. But I agree with the other guys in my hands, and I think they'll say the same thing. They look fantastic for the first 3, 4, 5 weeks. They open up the skin, the soft tissue. They're nice and round. They're so sexy. But then later on, there's not enough strength with the skin or the subfascia, and they tend to move around. They would be able to flip more, or you lose your lower pole, and then they fall down. Do you guys agree or disagree?
I agree, and I think in the setting of this weight loss revolution, you're going to be set up for even more problems, because now that skin's already been stretched, deflated, and now you're kind of giving this thin, deflated, stretched skin more to handle, and I think that's going to be challenging.
And you can see palpable. You can have palpable and visual deformities.
That's right. I switched because I was doing subfascials for a while, and I thought, oh, this is great. And same thing, Doug. A happy plastic surgery patient doesn't usually do long-term follow-up. So I would see him at that 6-week, even 3-month. I thought, oh, it looks great. Everybody's doing great. And then I had a patient actually bring me a photo of another patient that was like 2 years out from a subfascial placement, and it was just sagging, and you saw the implant from just the tissue thinning defect. And as I said, this can't work. That this is not good long.
And I don't think it's everybody that has a problem with subfascial stuff, but I don't think it's as predictable as intramuscular. And I think there's a lot of other factors that you're hoping work out.
Yeah, I mean, De La Pena has always done subfascial. Another question for you guys is about implants. When I started out, everybody was like doing teardrop implants. I've switched over just to doing round. That way I don't have to worry. Sort of like breast implants, anatomics. You don't have to worry about it turning. I think you guys may know this study where somebody showed with MRs that 75% of anatomic implants just end up just swimming around in a round pocket in the end anyway, with the pressure of the body on it. So just to eliminate one thing, and I mean, in full disclosure, my implant company makes anatomic ones. And at one point when I started, I thought, wow, with the man, I even want to make a left implant and a right implant, but I've gone 180 degrees the other way. I keep it simple. I keep it round. Then it's just one less thing that I have to worry about. Do you guys both use round implants?
I do. I think in general, what people are searching for when they're wanting their butt augmented is they would like it to be fuller and a little bit rounder and perkier. So what I usually talk about when we discuss that with patients is, yes, you have the option of the anatomics, but for the most part, if you're wanting a rounder, perkier butt, we should place a round implant to help us achieve that.
Right.
And also too, I mean, the breast you're going to protect, but you fall on your butt all the time. We sit on it, trauma stuff, a little bit of force. And to Doug's point, one, naturally, you're going to sit on it and stretch it, and that pocket's going to expand. So I just think that in my hands, I worry that you're going to be set up for problems of that rotating, moving. You fall from a bike, from skiing, whatever it is, and a little movement, is going to be a problem.
Great.
Absolutely. All right. Any other questions that you guys think that somebody would like to have answered? Do you do lymphatic massage? Any other things, any other post-op things that these guys need to know?
I think number one is if you're starting out, and you mentioned earlier, the smaller the implant you can start with, the easier this is gonna be. So 100% would do that. I think staying off that butt is absolutely key. I always tell everybody that the first 2 weeks that, if people aren't careful about this, if they're not truly taking care of this, it's going to be a pain in the butt for all three of us. Whoever's taking care of you, because they're going to be sending me a picture of your butt crack every single day, and so literally be a pain in the butt for all three of us. So really, really, and Matt hit on it. Being very stressful about they have to take care of this. Feel like a BBL, you lose the fat. Here, you don't take care of this, you'll lose an implant.
Yeah,
I agree.
right.
I agree, John. The one other thing I'd say that we do from in the pre-op counseling is I actually encourage the patients to start at that time, because we usually do pre-ops about 2 to 6 weeks before, kind of depending upon where they're located in the US, et cetera. And I encourage them at that moment, spend at least an hour a day, 2 hours a day, increase it every day. Try not to sit on the butt, because so much of that is just psychological, and you really want to make sure that that patient's going to be compliant. And if they give you a hard time and say, I can't do that, do not go through with that surgery. That just say that you're not a good candidate for this. It's not going to work.
Unless we touched on it in the last 2 minutes, what is the most likely cause, or what have you learned? What's going to prevent dehiscence both intraoperatively and postoperatively?
The biggest thing is tension-free closure. If that muscle doesn't close over that implant, very easily, you're set up for problems. You're just hoping for the best. So if that closes really well, even if you get a little wound healing, you're going to be fine because you got so many layers over the top of it. So a little skin issue is no big deal. I don't even stress about it because I got so many layers underneath.
I agree. Tension-free closure. And by that too, we just mean that, in a breast augmentation, you can have that implant sit close or near that incision, right? And close it. And for the most part, it's going to heal. That's not the case for a butt implant. It has to sit away from that incision. It can't put any pressure on it. If it does, it'll break it down.
Mm-hmm.
Yeah, and we're not sitting on our breasts, that's for sure.
No.
No, I think and what antibiotics you guys use in the OR and post-op?
I do Clinda, and then I give them 5 days of Clinda afterwards.
I just use Ansef, and then I give them a little Keflex.
Cool. All right, guys, this has been amazing. Tour de force, really great thought leaders. I want to encourage everyone to go see this, to tell your friends tomorrow, or if you saw an advertisement for it, to go ahead and look at it in the next coming days. And I also want to make a plug to see both of these guys, Matt and Johnny, to see their amazing 2 conferences, 2 courses at the Aesthetic Society in Vancouver in April. We'll see you there. All right. Thanks so much, guys. I really appreciate your help tonight.
Thank you for having me.
Thanks for having us. To see you.
All right. Bye. All right. Bye, guys.